Hi, everybody. We're gonna get started in just a minute. We're having a few technical difficulties. So just hang tight for a minute or two. Thanks. Okay, so we'll do them just, oh, do you want to go ahead and do it? Okay. All right, everybody, we're gonna go ahead and get started. Thank you for your patience while we had to take a minute to get everything up. Is this working? Can anybody? Is that working? Yes. Oh, okay. Hi, everybody. So we're gonna go ahead and get started. I don't have any announcements today, so I'm just gonna hand it over to Simone. There you go. Hi, I'm a postdoctor fellow in the healthcare team under Dr. Nancy Fleischer. I'm happy to present one of our guests of today, and it's about my topic is about the effects of anti-poverty policy on health and poor communities in. So I will just briefly introduce myself and the project that I've been doing since my PhD. And also I will present one of them, which is about the anti-poverty policy on health in Mexico. And I'll also briefly introduce current work that I'm doing in the health field. So my research interest fields are racial ethnic health disparity and also health effects of policy and intervention. I went to college in Korea and I did the master at Cornell University, and I also did my PhD in the University of Maryland. And I lived in Thailand for working, and I think that was the best time in my life because I really love Thai food. And yeah, there are two health disparity projects that I've been working on. The first one is about the anti-poverty policy, which is called Progresa, and health in Mexico. And for this project, I analyzed 20 years of effects of Progresa on adult mortality, child mortality, fertility, and also maternal health, and chronic disease like hypertension in poor and rural areas of Mexico. So for this one, I combined vital statistics with census, survey, and administrative data. And the second topic is health disparities among Asian Americans. I participated in the whole process of the project about the randomized controlled trial intervention study to increase colorectal cancer screening among Asian Americans. So I participated in the whole process, like survey design, recruitment, data collection, management, and writing manuscripts. Because of this experience, I became interested in health disparity, especially racial health disparity. So that's why I joined our helper team. And I'm still studying like topics like colorectal cancer screening status, slip hope, or multimorbidity among Asian Americans. Today, I will focus on the first topic. And there are two subtopics for this. First one is health effects of Progresa in Mexico, and the other one is effects of its recent termination on infant and maternal health. So I will start with the Progresa. So Progresa is also called as Prospera. It is the oldest and best-known anti-poverty conditional cash transfer program. So conditional cash transfer program CCT is usually designed and implemented to reduce poverty by making benefits conditional on the recipient's actions. So Pergasa provided per families with cash incentive conditioned on children's regular school attendance, families' health clinic attendance, and also prenatal and postnatal care. The program also provided health education seminars and also nutritional supplements. And cash payments were given to female of the family because in the pilot project, they just found that it is more efficient than giving it to the male of the family. And this is a detailed description of the progressive benefits by each component. So there are 3 components here for education components. Cash was given per child attending school, and the amount increased with each grade. And girls received higher cash than boys because they had higher dropout rates, especially from middle school. And health and nutrition components targeted all households, but it has more significant emphasis on mothers and young children. And the services were provided by public hospital or clinics. So this Progressa program was introduced in poor and rural areas in 1997, and it was expanded to urban areas around 2000. And in these poor and rural areas, they're suffering from intergenerational poverty and high mortality, high fertility, especially high teenage pregnancies, and also high school dropout. So this program has been modeled for similar CCT programs in more than 60 countries, including US. And several studies found that programs improve education, wage, employment, and also health. The amount of cash is quite large. It led to 25% increase in household income for in extreme poverty. And the monthly benefits per household was 800 peso, which is around 42 US dollar. And the budget for this program was around 0.5% of total GDP. And this figure shows the number of Progressa beneficiaries over time from 1997 to 2010. It is expanded over time across all the municipalities, especially in poor areas. So this is the map of Mexico. Darker areas are high and very high poverty areas, and my analysis are all focused on these marginalized areas. And this figure shows Progressa intensity in non-poor areas and poor areas. So Progressa intensity is just the proportion of program beneficiaries, which equals the number of household beneficiaries divided by total household. So you can see dramatically increase in poor areas rather than non-poor areas. But there has been little research has been done for the Progressa's long-term nationwide effects on health, because previous study usually used just survey or evaluation data, which is only available for 1 to 3 years. So I used nationwide data from 1990 to 2010 to study longer term of programs' impacts on fertility, child mortality, and maternal health indicator in poor and rural municipalities. So this shows the trends of the outcome variables. The first one is fertility, and the second one is under 5 mortality, under 5 child mortality. So first one is the fertility by age group, women's age group. You can see a larger reduction overall in 4 areas. And under 5 mortality also, there's a larger dramatic decrease in 4 areas. So I just wonder whether this larger reduction was caused by Progressa. And this also shows the place of delivery in non-poor and poor areas. So in 1990, the institutional deliveries was much lower in poor areas, and home deliveries was much higher, like more than 60% of deliveries were conducted at home. But their proportion was switched since 2000. So I was wondering, like, Progressa may affect those trends in poor areas. So I will talk about the mechanism that Progressa may affect these health outcome variables. So for fertility first, Progressa may increase fertility because the benefits increase with the number of children. But Progressa may decrease fertility as well because public health lectures emphasize family planning, or parents may want fewer children so that they can invest more in each child. And also young women, teenage women, they need to attend school to get this cash incentive, so it may decrease fertility. And previous studies had conflicting results. So 3 of them did not find any effects on fertility, and only one paper found that it reduced fertility, particularly among teenagers. But all of this study had limitation that it is limited to the first few years, and that they did not use nationwide data because they use only either evaluation data or survey. And this is for child mortality. Progressa might decrease child mortality because its benefits were designed to improve health and nutritional status of children, like they did growth monitoring or regular health checkup, and also the immunization. Also, mothers all received prenatal or postnatal. And surprisingly, there is only one study on this topic. Bahram found that Progressa reduced infant mortality by 17%, but it is also limited to the first few years. Finally, it's about the maternal health, the place of delivery. Progressa did not have any direct cash incentive on the place of delivery, but it might be affected by Progressa because it had income effects. Because of disclosure income, mothers may use it for better place of delivery services, and Progressa also required pregnant women to visit clinics, which may introduce more reproductive and health services. And Progressa also required women to participate in health medication seminars, which emphasize the importance of place of delivery and more medical care during the deliveries. And only one study found that Progressa increased yield and timeless delivery in rural areas, but it also has a limitation that the data is used. They used the data in early evaluation data in 1997 to 2000. So I have 3 hypotheses here. First, Progressa reduces pregnancy among young women because of the requirement on school attendance, and also ambiguous effects on fertility among older women in poor municipalities. My second hypothesis is that Progressa reduces under 5 mortality in poor municipalities. My third hypothesis is that Progressa reduces childbirth at home and increases institutional deliveries in poor municipalities. So here is the data and method section. I used all municipality level data from 1990 to 2010. I combined wider statistics, both administrative data, census, and property data. And all of this municipality codes should be recorded back to 1990 because the boundaries of municipalities have been changing over time. They collapsed or combined or divided, and new municipalities were created later. And there are 4 outcome measures here. First, age-specific fertility rates is the number of live birth per 1,000 women by age group. And total fertility rate is the number of children born to a woman in her lifetime. And under 5 mortality rate is the number of children who die by 5 years of age per 1,000 live birth. Finally, place of delivery is just proportion of institutional deliveries versus home deliveries. So my main model is difference and difference estimations using variations from program intensity across municipalities and over time. So here is the equation. So Y is all the outcome, fertility, mortality, and place of delivery. And program intensity is just proportion of household beneficiaries, which is beneficiaries divided by total household in each municipality. And I included municipality characteristics as control variables. So it's proportion of illiterate population and proportion of household without pipe water and also without electricity. And then I include effects on municipality and year. Here I use 1, 3, 5-year lag program intensity to see short and longer term effects. And before doing the main analysis, I check the pre-intervention trends. So there should be similar trends across municipalities before program started. Basically, I just run the same regression just before this program started, because I have to test whether the health outcomes are different by level of program intensity, which should not be different because the program before the program started, this outcome level can be different, but the trend should be similar for causality of the program. So basically, there is just same analysis, but I have to create this variable, which is called a worker variable, because I use continuous treatment variable. So I just created group variable by classifying the municipality into 1 to 5 based on program intensity. So this sigma should not be statistically different 0. Then the program pre-intervention trends will be similar. So this shows the sigma over time before program started from 1990 to 1996. 1996 is not represented here because it's group year. This is for total fertility rate, and this is for under 5 mortality. So I found that group 5 has a significant difference from 0 in some years. So group 5 were excluded in my whole analysis, but for other outcomes like under 5 mortality or place of delivery, I did not find any significant difference in pre-intervention trends. So now this is the main results. It shows the effects of Progressa on total fertility rate in poor areas from 1990 to 2010. So I found that Progressa reduced 0.3 birth per woman for her lifetime. And this becomes more significant in the 3 or 5 year specification, which means it has more significant longer term effects. And then I look into the effects for a specific fertility rate. For the teenagers, it is very significant. So it means 13 to 18 birth decrease for every 1,000 teenage women. I also found reducing effects for older women as well, especially for those aged 13 to 34. And this is the effects of Progressa on under 5 mortality in poor areas. So I found that for death per 1,000 birth decreased because of Progressa, but it is not lasting when I use 3 or 5 year lag specification. And a slightly larger effects for female, but their significance disappear in the longer term. And then I look into the effects by cause of death. I found a decrease in infectious and parasite disease and marginal reduction for the conditions originating in the perinatal period. For infectious and parasite disease, maybe because Progressa provided treatment for parasites or rehydration salts, so which makes sense. And then I looked into final outcome variable, which is the place of delivery. I found that institution deliveries were increased by 11 percentage points, and home deliveries decreased by 12 percentage points. And those effects were larger and more significant in the longer term. So this is summary. Progressa reduced teenage pregnancy by 13%, probably because school attendance requirements. And it also reduced childbirth of older women, maybe because of they received health records emphasizing on family planning, and also they may want to invest more in each child. I also found that Progressa reduced child mortality by 19%, probably because of preventive healthcare services and also prenatal or postnatal care. but the effects was only temporarily. I also found that progress saw increased institutional deliveries and also reduced home deliveries, probably because of income effect, clinic visit, and health education seminars. But my study has some limitations. First, I think effects of child mortality may be underestimated because of underreporting problem. I found that many child deaths are not reported, especially in poor and rural areas. People have the custom of burying their children when they died, and they don't have any transportation to report their children's death. So it might be underestimated. And the second one is I initially planned to look into the effects on maternal mortality ratio, but I was not able to do that because maternal deaths are rare events. So Nepal or India also has similar CCT programs, and they some people tried to look into the effects of maternal mortality ratio, but they also had a similar problem that maternal deaths are quite rare events. So they also reported that they cannot see them as the main outcome variables. And now I will talk about effects of its recent termination on infant and maternal health. So in early 2019, maybe May 2019, the Mexican government eliminated Progresa. So the education component was replaced by 2 scholarship programs, which still have some problem, but there is no replacement at all for health and nutritional benefits. So considering that program has really positive effects on child and maternal health, the sudden elimination might adversely affect infant and maternal health. So these are the graph of infant mortality and place of delivery in non-poor versus poor areas. So infant mortality has been quite constant in both areas, but there's an increase in 2017 and also a sudden increase in 2019 only in poor areas. And for here is the place of delivery. In poor areas, the institutional clinics has been steadily increasing from 2010 to 2018, but it has been like a stable in 2019 here. And home deliveries also has been steadily decreasing since 2010, but it becomes also kind of steadily becomes stable in 2019. So I just wonder maybe this they are affected by elimination of Progresa. So I have 2 hypotheses. First, the elimination of Progresa may increase infant mortality in poor areas because of the increase in particular cause of death. And the second hypothesis is that the elimination of Progresa reduces institutional deliveries while increasing home deliveries in poor areas. So data and methods are quite similar. So I combined wider statistics, both administrative data, census, and poverty data, and I used data from 2018 to 2019. And main comparables are infant mortality and place of delivery. Infant mortality is number of deaths before the first birthday per 1,000 live birth. And place of delivery is just proportion of institution deliveries or home deliveries. And model estimations is also very similar. Outcome variables are infant mortality and place of delivery. And my main exposure variable is program intensity multiplied by elimination here. So elimination and program intensity is the proportion of accumulated beneficiaries in 2018, right before the elimination. And this elimination indicator is just dummy variable, 0, it equals 0 for 2018 and 1 for 2019. And this beta 0 will capture the effects of eliminating Progresa. And I included effects on municipality and year here. And this is the effects of elimination of Progresa on infant mortality Although they are all positive coefficients, I did not find any significant coefficients. But as the aggregated disease can mask the significant findings, I look into the cause of death. And I found an increase of 0.52 infant death per 1,000 live birth because of infectious and parasite disease. And also there's a marginal increase of infant death because of respiratory disease. And this is the result for place of delivery. Oh, again, there's a negative effects on institutional deliveries and also positive effect, coefficients for home deliveries that they are not statistically significant. And then I did classification tests. It's basically running the same analysis using 2017 to 2018 data just before a program was eliminated to demonstrate that model estimation was valid. So before a program was eliminated, program actually had all negative coefficients for infant mortality, which is also same for cause of death. And actually, before the program was eliminated, it actually increased the institutional deliveries in poor areas. So this is my summary. Overall, there's a suggested evidence of reducing effects on infant mortality, but they were not statistically significant. However, I found that proposal led to an immediate increase of infant death because of infectious and parasite disease, and also marginally for those due to respiratory disease. And I did not find significant effects on the place of delivery. And the limitation of the study is that I only use 1 year of data for cost elimination of the program, so more evidence should be found. And now I will talk about my current research work in the helper team. I'm using the data called MePress data. It is a representative survey of adults with a positive COVID PCR test, who are also registered in the Michigan Disease Surveillance System. I'm looking to racial discrimination in healthcare settings and also COVID stigma. So for the first topic, I'm trying to look into the prevalence of racial discrimination in healthcare settings and its association with mental health outcomes. So my main exposures are perceived racial discrimination in seeking healthcare for COVID and also getting testing or treatment for COVID. And my outcome variables are depressive symptoms and anxiety symptoms. And another project is about COVID stigma, studying the prevalence of COVID stigma by socio-demographic factors. And relevant variables are stigma because of people thinking the respondents might have COVID. So it is measured by 3 items. First one is people acting as if they were scared of respondents. Second one is being treated badly or without respect. Third one is being threatened or harassed. And another variable is being afraid of disclosing COVID diagnosis to family or friends, and also at work for only employed populations. So this is the end of my presentation. Please let me know if you have any questions. Yep.
So I was very for your comparison study, like we know that so over the past years, that was that's like very
Oh, you mean the access to healthcare might be affected by elimination progress?
The changes that we saw very, study period, that don't vary by except for folks that access to abortion or.
The problem is that I use municipality level data. So there are not many variables for maternal health indicators. The only variables that I had for vital statistics were place of delivery and skill attendance were there or not at the delivery time, and also maternal mortality. So I was not able to look into effect modification by access to healthcare, unfortunately. But I know there are some survey data on that. And I know some of my colleagues are working on the effects on those access to healthcare, but I did not use that as random modification. But I think that's really good suggestion. But I think I need to look into it as individual level data rather than area level data. But yeah, thank you for your comments. Question?
I was just wondering, whoever gave us the question, what made you interested in the progressive program and helping people more broadly? How did you get interested here?
I had a chance to look into this program when I in the conference named PAA, Population Association of America, and they were talking about the program effects, especially in Latin America. So I became very interested in that. And when I applied for a PhD program, I contacted a professor who is working on this program. And when I was admitted, I worked on those projects, like how to measure the effects of this progress, or another program is named Secular Popular, is health insurance program on adult mortality or hypertension, something like that. And become, yeah, this is interesting to me. So yeah, I just decided to work with professors working on this project.
Yeah, and you can still in the future what we're doing for health policy.
Yeah, I'm still working on my previous advisors on these topics. And since the program is recently terminated, it's still interesting to see its recent termination effects. Although the data might be suffering because of COVID, especially vital statistics might be very underreported. But it has that problem that we're still working on looking at the effects of progress and also termination of progress. Yeah, I'm still working on this.
Right, thank you.
Thank you.
Thanks, everybody. We'll see you in 2 weeks.